Welcome to Variations 4, the musculoskeletal unit. We're going to be talking about question number 4 to 11 right now. Really the main focus of these questions is joint surgery or joint replacement surgery with a focus on knee and hip surgeries. But first, number 4, joint erosion, what can cause it? Fairly intuitive stuff at the top of map 5. These things up here can all cause destruction or gradual erosion of a joint, which has some obvious, the triangle, symptoms and signs, and diagnostics hopefully are fairly straightforward for you as well. The treatments, well, causing inflammation in these areas from the erosion and damage, and anti-inflammatory meds seem to make sense, analgesics, and immune suppressants depending on, what's causing the issue. But don't forget, immunosuppressants can also help to decrease inflammation as well, because inflammation is part of the immune response. The next question, 5, talking about synovial membranes. So let's just kind of dig into that a little bit here, what we do about issues there. So there's a connective tissue that lines the joints, and it can become thickened. Oh, how does that happen? What does this remind us of that we talked about in the previous unit? What can cause thickening of this tissue? What can cause thickening of the synovial membrane? Well, it's right here, and hopefully reminds you of previous units. Inflammation, remember that. Chronic or severe inflammation can cause tissue to thicken. And what happens when tissue thickens? It becomes rigid. It takes up more space. We saw that in the GI unit. Now, this thickening, rigidity, and taking up space is not a good thing in a joint. Wouldn't be a good thing to happen in a joint that needs that easy movement. And so the obvious triangle symptoms, range of motion goes down, pain goes up. So what they can do is what's called a synovectomy. And what they're basically doing is using an arthroscope to go in there and take out some of the synovial tissue. Eventually, though, it does regenerate and it may thicken further. So there may come a point where they cannot repeat the synovectomy anymore, and we have to start talking about arthroplasty, which is replacement of the joint. Which leads us into question 6. What is the difference between a partial and a total hip arthroplasty? Let me answer that one straight up with pictures. So let's go to your PowerPoint that's off of your Moodle, and let's just look at that. So let's talk about this in general first. So I'll address some other questions here too, because it just makes sense to do it now. So what you see here, never mind the fact that we're looking at a prosthetic here, let's just talk about this in general. This is obviously the femur here. This is obviously the hips, the pelvis, and this is your hip joint. So this area here is called the intracapsular area. And basically what that means is any area that is inside of the joint itself. So if I have an intracapsular fracture, it involves either the ball, which is attached to the femur, or the socket that it sits in called the acetabulum. There's a ball and a socket. This is, again, these are prosthetics, but we all have them now naturally non-prosthetic. That's the acetabulum, and that's the ball that sits inside of it. That's called the intracapsular area. If you have an intracapsular fracture, you're getting either a partial or a total hip replacement, which we'll talk about in a minute. If you have what's called an extracapular fracture, It's happening outside of the joint area and just could be kind of on the femur itself, in that kind of area. But they still could call it a an extracapsular fracture. So the question at hand is, what is a total and what is a partial hip arthroplasty, hip replacement? If you only have to replace the ball portion of the hip joint, that is called a partial hip replacement. If you have to replace the ball and the socket, the acetabulum, then that's called a total hip replacement. Either one of those surgeries, partial or total, both of them, it requires the same hip precautions post-surgery, which we'll talk about in a minute. If you have an extracapsular fracture only, we'll look at how that's held together. It doesn't strictly require the hip precautions as the intracapsular fracture because it doesn't involve a joint. But many times you'll see professionals observing these precautions for comfort of the patient who has an extracapsular fracture. Let's go a little further with these pictures. So you can see here the hardware that they'll use for total and partial hip replacements. So this gets hammered into, they drill out the femur, they hammer this in, and they will either cement it in or they'll let the bone grow around it to hold it. Then they put the ball on top. And if that's all they do, that's a partial. If they do that, plus put in the new acetabulum, then that's a total hip replacement. For the extracapsular fracture, they'll kind of implement this hardware here. This is looking at picture B. It's called an IM nail, and they'll nail it into place in the bone. And this just holds that fractured bone together. But it's not, you can see the joint itself is still the original joint. So it hasn't been an intracapsular surgery. It's been an extracapsular. Like I said, this is called an IM nail. Intramedulla nail or something like that. But it doesn't involve the intracapsular area. Okay, so I believe that takes us to the next question. We may have covered more than one question actually in that little discussion. So what's the difference between indication for cemented and cementless hip? So let's look at map number 6 here. So I just showed you a picture of how they will hammer in the prosthetic into the femur, which is the ball portion of the hip joint on the end of it. So this would be either for a partial or a total hip replacement. If the person's a little bit older and it's approximately maybe less than 25 years to live, they'll use cement, and they'll cement it in, let the cement dry, and that's what holds it in place. They'll do that because again, cement dries quickly, so the person can go full weight bearing much quicker. It doesn't last more than 20 years or so, 25 years. And so that's why they usually reserve it for the older clients. A cementless has holes in the prosthetic and eventually will allow bone to grow through them. And the bone growth is what holds it in place. Now, the downside is it takes a lot longer for that to really take hold in the sense of full weight bearing. So rehab's a little harder. The patient has to be a lot more careful on how much weight they put on, for however long the surgeon prescribes. But the good news is that once the bone growth happens around that and through that prosthetic, it will stay in place much longer than the cemented one. So question 8 wants us to talk about hip precautions. So, and Just by the way, we've already talked about question 9. That was the intracapsular, extracapsular stuff. So just talking about hip precautions, I think, we've got it summed up here in, let's look at it 2 ways. Hip precautions, they happen for about 4 to 6 weeks. And here's the reasons why it's needed. Muscles and tendons need to heal, and they provide the stability to the ball and socket. So remember, these hip precautions are for the total hip replacement. We're talking about a joint that can pop apart quite easily. The ball can pop out of the socket quite easily until these muscles and tendons heal. So you want the angle of the hips greater than 90 degrees, no adduction past midline, and avoid leg rotation. So what does all that mean? Is there a better way to kind of talk about that? Yes, there is. And let's look at a diagram here. So if we just look at your hip precautions, right out of your Moodle, then you can see that here's that one piece of advice. Keep your the kind of this angle here of between your torso, pelvis, and upper leg at 90 degrees or greater. For example, this would be considered less than 90 degrees, obviously. That's a no-no. Do not do that, because what that's going to do is put pressure on that joint, and that joint could pop apart. Same thing here. This person's lifting up their knees above their hips, and they're making that angle less than 90. They put pressure on the joint, could pop apart. So again, the piece of advice is keep the angle, however you want to describe this, at 90 degrees or greater. I like to describe it to patients as always keep your knees below your hips. Okay, the other one that was discussed was not crossing your legs. You don't want to cross your legs over or take any one leg and take it beyond the midline of the body, because again, that puts pressure on the joint and it could pop apart. So we often will put a pillow between the patient's legs to remind them and actually help them when they're sleeping so that they don't cross their legs. But we do it when they're awake as well. No crossing of the legs. And this is for 4 to 6 weeks. Let's avoid twisting. They say rolling your hips. I call it twisting the feet, twisting the leg. Let's avoid twisting that leg, or what they call rolling the hips. It puts pressure on the joints. Okay, now I believe we are moving on to the next question. Let's go back to our maps. The next question is about knee surgery. So compare and contrast just making sure we covered everything here. We have. Compare and contrast total partial knee arthroplasty. And that was map number 6. So another type of joint surgery here. So the reasons for getting the knee arthroplasty are the same as we discussed above, that destruction or deterioration, with the obvious symptoms and same type of intervention here. You've got 3 points to the knee. There's the femur head, the end of the femur head there, with that above the tibia plate, with the patella in between. Hopefully we have a basic understanding of those. Now you can have any one of those components or all of them replaced. A partial knee replacement will involve one of those pieces, and a total will involve them all. the big thing, and we're going to talk about this in the next question, is whether it's a total knee replacement or a partial, you're still looking at the same types of neurovascular checks. Same thing with any of your hip surgeries. So in some ways, from a nursing point of view, we approach these in similar ways. So your patient's going to come back after knee surgery with a huge gauze wrap covering a good portion of the whole leg. Underneath that, tensor wrap is a huge gauze foamy dressing. It looks massive. It peels off quite easy, and what you're left with is a basic surgical incision over top of the knee with staples in situ. And I forgot to mention that for the hip, same deal in terms of the dressing. It's just a simple incision around the hip area with, top of the femur type area with some staples in situ. Considering the brutality of the surgery, the dressings are quite minimal. The incisions, are quite minimal. Anyways, important to note that this compression dressing stays on for a day and is usually you need an order to take it off, but it stays on for the full day, 24 hours. In terms of leg positioning for knee surgery, usually just a natural resting position, not really encouraging you to put the leg on pillows because we want to avoid hyperextension or hyperflexion of the knee. I want to keep it in a natural state. Physio will work with these patients to try and to get them back to comfortable flexion of the knee. It takes about 4 weeks or so. Okay, question 11, the last question here, asks us to look at the head-to-toe diagram for just generally for patients with joint surgery. So let's just go through this and see if there's anything that's not intuitive. A lot of it, as you read through, hopefully is going to be fairly intuitive. I don't need to speak to it. Any of your post-op patients are at risk for pulmonary emboli. In fact, though, not sure why it's not mentioned here, but what besides pulmonary emboli are your, especially any patient that's had a fracture of any kind, what are they at greatest risk for? It's a fat emboli. Fat can be released from fractures, can be either sitting around in the lower extremity, and at some point gets dislodged, could be days after surgery, it gets dislodged and ends up in the person's lungs. Could be when they get home. So this stresses the importance of immobilization prior to surgery, so that there's no kind of scraping against the fracture area and allowing fat emboli to be released. Pneumonia, anyone's at risk for pneumonia who's in bed for a long time and is at risk for atelectasis, which can lead to pneumonia. A lot of the stuff here is pretty straightforward. Want to monitor your hemoglobin, your hematocrit. They've lost blood in surgery. Sodium for dehydration, your vital signs. They might need IV fluids. They might need blood. Skin breakdown, they need to be repositioned every 2 hours. Post-op in general has the risk of urinary retention, especially when there's anesthetics used, narcotics used. If they've used a catheter through the surgery, that can cause lazy bladder or inflammation of the urethra. All these things can cause urinary retention. Might need an in and out Foley. Acute renal failure, decreased urine output. Anyone's at risk for that who's not drinking or getting enough IV fluids. Pneumatic stockings, this doesn't just apply to ortho patients. This applies to many patients who are going to be stuck in bed for a little bit. These pneumatic stockings wrap around the leg and they fill with air automatically and then release, and they're mimicking the flexion of the muscles when you walk. So they're mimicking that kind of flexion. They're very gentle in their compression, and they promote blood return to the heart. If you ever take those off, you're supposed to take them off at least once a shift to check skin condition underneath and maybe do some basic care, but they shouldn't be off, check the protocol in the hospital. Some of them say no more than an hour. I'd like to say no more than 20 minutes. Let's put them back on. Why do they need to stay off for that long? But check your protocols. Risk for infection, so all that stuff's pretty intuitive. Anyone's at risk for DVT. Just in general with DVTs, with any kind of coagulation, we could do a D-dimer test if we wanted to. The D-dimer would tell us if there's clot degradation product in the bloodstream. If there is, if the D-dimer is elevated, it tells us that there could be a clot in, it tells us that there's a clot somewhere in the body. It doesn't tell us where. So then we have to do maybe, if we're worried about the lungs, we're doing, spiral CTs. If we're worried about DVT, we're doing Doppler ultrasounds. Why would you do a D-dimer then? A D-dimer is helpful because if you get a negative D-dimer or a D-dimer that's not elevated, then you can rule out a clot and you don't have to do this expensive imaging. Want to encourage foot exercises. Patient will be on anticoagulants. They'll be going home with anticoagulants. Just a note on that down the left-hand corner here. Deltaparin is usually the drug of choice, or enoxaparin, some kind of low molecular weight heparin. They'll be on it for a couple of weeks, so they have to be taught how to use it. The beauty of it is that you don't need to do any coagulation monitoring. They don't need blood work done for INR or PTT. It's a very predictable range that it works in. We don't have to monitor those things in the hospital or the community. We might be monitoring them for other reasons, but not for the deltaparin itself. Some people can't use the deltaparin, so they'll go on home with warfarin for 3 weeks. For that, of course, you do have to monitor your INR for sure. I want to stress again that neurovascular checks, which we'll talk about in the INP, are huge. It has to be done for these patients for any joint surgery. Arms, legs, whatever. We got to do neurovascular checks. We'll talk about what those are in INP, but essentially you're making sure that no nerves are damaged or are being impinged upon by way of swelling, and you're also making sure that circulation down to the end of the extremity is adequate now too. Neurovascular, it's all in the name.